interesting series in the past, and this time we are coming up with nuances and problems in lumbar spine treatment for spine surgeons, orthopedic surgeons, and neurosurgeons all across the globe. And it's a learning for you as well as for us, because we will be having didactic cases, only discussions, and hearing it from the horse's mouth. We have a lot of stellar faculty with us. We have my co-convenor, my very dear friend, Dr. Abhay Nene, with me. And I welcome you, Abhay. Dr. Nene is practicing at Mumbai, and we all know he's a big academician. And thank you for this series which we have started in 2020. We have a stellar faculty. I just would like to introduce quickly. We have Dr. Vishal Kundani, one of the stellar and renowned spine surgeon, we can say world-renowned spine surgeon, Dr. Vishal Kundani, with us, who will be sharing his knowledge with us. And he is the India chair currently of the AO Spine SIN. He is the chairperson for India. And we have Dr. Guru Raj Sangodimat, the education man who is reformed the Indian education system with ASSI, the AO Spine everywhere. Dr. Guru Raj is seen with Delhi Spine, Mumbai Spine everywhere. And we welcome you, Dr. Guru Raj, who is at the helm of Indian Spine Injury Center as a senior spine surgeon and unit head. We have a neurosurgeon, Dr. Umesh Srikanta, working in Bangalore, and he's one of the phenomenal minimally invasive spine surgeon. At the same time, he does endoscopic work. He does a lot of deformities, O-lifts, and all the difficult ones Umesh is known for, and he's presented his work all over the world. We welcome you on board, Dr. Srikanta, for today's webinar. We have our own Pune team along with us, the Pune Association of Spine Surgeons. In today's webinar, we have Dr. Shardul Soman, who is practicing at the Lokmanya Hospital and the Naule Hospital in Pune, and he's doing phenomenal work. He's doing a lot of work on advances, K-lifts, and cervical spine surgery. Welcome, Shardul, on board. We have Dr. Himanshu Kulkarni, who is practicing in Twin Cities in Maharashtra, one of the blue-eyed boys of spine surgery. Himanshu is practicing at Sangli and Kolhapur jointly, and he is having phenomenal work in endoscopy and minimally invasive surgery. And he is a great avid researcher with us. We have Himanshu will be speaking on the review of literature along with the interesting case. We have the upcoming spine surgeon from Pune, Dr. Bhushan Patil, who is practicing at Ruby Hall and Noble Hospital, and he will be sharing his experience with us today. I think I would like this webinar is started on behalf of the Pune Association of Spine Surgeons, as we are coming up with the ASICON 2026 in January. I welcome you all, and I would like to invite you all to register for ASICON 2026, which will be held on 22nd of the Jan 2026 at JW Marriott. We have a lot of interesting sessions in ASICON this year, where we are having ASICON Studio, ASICON Stadium, debates, and case-based discussions. A lot of new and advanced spine surgery stuff which we will be having. I would like to invite Dr. Rajesh Parasnis, who is the president of Association of Spine Surgeons of Pune, to say a welcome note, and then Dr. Abhay Nene to take over and start the proceedings. Rajesh.
Thanks a lot, Shailesh. First of all, let me congratulate you and Abhay for taking this great endeavor, for educating all of us and letting us participate. On behalf of PSSA and the organizing team of ASICON 2026, this is, sort of introducing to the practical aspects of spine care, and also to encourage people to include the academics as essential component of their practices, and also to encourage registrations. So all the panelists, Dr. Abhay especially taking time off from busy practice and teach all of us over here. Dr. Vishal and Guru don't need any, introduction, as we already said. And we are all excited to share the dais with the young upcoming surgeons also, Dr. Umesh, Dr. Shardul, Dr. Bhushan, as well as Dr. Himanshu. So it will be a great endeavor going forward, Shailesh. Congratulate on taking this endeavor. We are all excited to learn.
Yeah.
Thank you so much.
Thank you, Dr. Parasnis. And invite my colleague Dr. Abhay Nene to talk about in brief about the webinar today, and Dr. Bhushan will start the shots.
So the great man actually said that there are two types of spine surgeons in the world, or spine surgeries in the world. One that converts leg pain to back pain, and the other that converts back pain to leg pain. So leg pain has been a bane of all our lives, and especially it's a problem if it happens after surgery. And you go on a post-op round and you expect the patient to say, "I'm fine, my back hurts." But when he says, "My back hurts, but sir, my leg pain has not gone away," or "I still have the same leg pain," or "My leg feels numb," that doesn't go well with you, and you have a sleepless night. You're dying to go back and see that patient the next morning, and you expect him to say, "Okay, overnight I'm fine," but he says, "Actually, the leg pain is now worse than before." And this is a scenario that all of us have been, have faced with in life. And if you haven't, you've not done enough work. So, in a webinar like this, which is Spine Connect, it's the idea is to get you, get you a reality check, to get you to come to terms with real life situations and how experts handle them. And sometimes it's TLC, sometimes it's deep diving into the problem. And what we've done today is we've segregated the problem into a variety of etiologies, and we have some rockstar presenters, and they're going to talk about one aspect of this post-operative leg pain. But what we would invite you as viewers to delve into is to identify what are the learning points, and in the end kind of we'll summate everything that we learned today. So I think let's invite our first speaker, who's Dr. Bhushan Patil, and I'm not going to disclose his topic because he's going to spin it around for us. Over to you, Bhushan.
Yeah. Thank you, sir. Thank you. Good evening, all. I'll be sharing my screen now. Is it visible?
Yeah.
My screen. Yeah. Thank you. First of all, I would like to thank Shailesh sir for giving me this opportunity to present in front of the stellar faculty. It's really an honor. I'll straight away start with my case. So this is a 53-year-old female presenting with low back pain and radiation to both lower limbs associated with tingling and numbness. She had a reduced standing and walking tolerance. Her neurology was intact and she had no known medical comorbidities. Her X-rays showed a degenerative listhesis at L4-5 level. These were MRI pictures showing significant stenosis at the L4-5 level, with the axial showing significant facet effusion as well. She was operated elsewhere with the L4-5 MIS T-lift done 6 months ago, and she was improving clinically. Now she presented to us a couple of months back with a history of slip and fall, and now is when we come into the picture. So she had complaints of severe back pain with severe left lower limb radiculopathy. VAS was 8/10. She was not able to stand and walk. Her neurology, thankfully, was still intact. The X-ray is clearly showing a cage back out uh, at the index level. So these were her MRI pictures.
What next?
I think the
Like
question
Dr.
we asked
Guru
here should be taken up by the rest of the faculty. Maybe Guru, since he's staring at my face.
Bhushan, can you go back to your immediate post-op X-rays?
Yes, sir.
Okay. So the looks the same, and yeah, and
Is there any telltale sign, Guru? Why did you ask for a pre-op the post-op X-ray? Is there a telltale sign you're looking for?
Yeah, basically, I was just looking for the rotation. There is not much rotation. So on the screws on the left side,
probably it looks like going outwards.
Going out of the pedicle, maybe just extra pedicular. And
so
especially
one takeaway as we see is that the cage only has as good a hold as the screws have.
Yeah.
So if you've got shitty screws, the cage is going to be on shallow grounds, isn't it?
Yes.
Yeah, and maybe what do you think, Abhay? A lot of time, even if you see such picture, maybe that cage is holding and probably you get away. But a lot of time you don't get away because it is a problem. You're not done it right. It's a day one problem.
Correct.
And what was her age? You said
she's 53 years old.
53. And can I see just pre-op MRI once again?
Yes, sir.
Okay, go back.
Rajesh, can we get you in here and ask you what do you feel about the height of the cage? Are you a proponent of putting in, massive tall cages, or would you like to just have a snug fit?
No, actually against it, Abhay, I mean, there is literature evidence also when you try to jack up the height, there are higher chances of something going wrong. I also don't like to distract my screws while putting the screws anyway, before putting up the cage. Now, one more thing I want to add over here is you see the cage placement. In MIS TLIF, usually it's more oblique. Here, this entry, if you see the AP, and later on also when it is backed out, it's coming into the center. So sometimes this is after retraction of the dura. So many a times, if you're doing a classical MIS TLIF, the corridor is such that even if it backs out a bit, it doesn't impinge on the roots. But this is extremely risky, right? So when it comes to cage back out at 6 months, then you have to think of pseudarthrosis also, because by 3 months, it's supposed to gum up. I do agree if the implant hold is not good, it's going to back out. Any which ways, it cannot hold for long. But by 3 months, if there is a semblance of fusion, this kind of situation can be reverted.
Yeah. Vishal, what is your take on this? If it is operated by you and this patient comes to you and he's got borderline pain, not very bad, managing, but on and off pain in the leg. What will be your suggestion, Vishal?
At this stage, the screen is showing a post-op image. Are you
Yeah, the
talking about
next
this
one, the
stage?
next one. At this stage, he is still managing. She is still managing, but some pain on and off, and no deficit walking, but pain on and off in the leg.
So few things I would surely want to talk to the patient in great detail.
Yes.
One is, like we all spoke, that there is an implant which doesn't look the most optimal, though post-operatively we found it in optimal place, both the cage also, and as I can see the screw on the left side, particularly the L5 one. L5 means the sacralized, the lumbarized S1 or the sacralized L5. Now that implant on the left side doesn't seems to be in the most optimal position, and also informing the patient that the cage has backed out as well. If this is a sudden occurrence after the fall and the symptoms have newly appeared which were never there for last 2 months, then I'm surely concerned. So it is the pattern how the symptoms have appeared, how bad the symptoms are, and how they are disabling to the patient. Based on this information, whether I have to wait and watch, observe, or I have to get aggressive to reposition the implant in more optimal manner will be a joint decision with the patient.
Got it.
Because even at this stage, just because a cage looks suboptimal, I'm really not sure whether it is the cage slip out which is the cause of current pain, because this might have happened like 1 week or 2 weeks later after the surgery and it remained silent for all this while, and something new has happened today. So one, I would surely bring this to the notice of patient that we are looking at a suboptimal implant, probably due to cage pullout or a screw which seems to be cutting through laterally and also superiorly into the end plate. Whether this is the cause or not, we are really not 100% sure, but yes, it seems to be the most probable cause, and a repositioning in that situation might help. Like Dr. Parasnis pointed out, the cage is straight backward. It is not left, it is not right.
Yeah.
I'm really not sure whether that is the only thing. And in conjunction with the understanding of this, the patient and me will take a decision. If
Vishal,
everything
can
is
I
left
put
to
you in
me,
a corner? Vishal, can I put you in a corner that in a real life situation, you've disclosed to the patient. Guru, I know you've raised your hand and we'll come back to you in a second. But I want Vishal's input on how he would handle the question from the patient saying that, sir, you said the surgery went well. I've had this minor fall and now you're saying that I might need a resurgery. Do you think there was a problem in the surgery that you did? This is the natural question that your patient is going to ask you. So can you tell us how to handle that?
Very relevant question. I think the communication part, I think Dr. Abhay, I have learned this from you. I have heard this, how to handle the communication part. One is handling the clinical scenario, and second is handling the communication with the patient and relatives. I think the first thing to bring them in confidence is to give them a space to put up enough number of questions and then answer them properly. And what is the proper answer is to run them through exactly what you had done, exactly what was done, and why you felt okay immediately post-op, and what could have been the reason of this happening and what is required. So if I have to tell them in stepwise manner, I'll tell them that we generally put screws, we generally do decompression, we we generally put in a cage, we generally place the cage in such a manner, we generally do it this manner. This is what is mentioned in literature, and this is precisely what we did in this particular case scenario, and we found it optimal intraoperatively. Generally, we check whether the cage is suitably snug fit intraoperatively by this particular maneuver. So this was required, and this was done, and we found it optimal, and that is why we closed and came out. And with this, usually 95% of patients will do well. However, sometimes either due to fall, or there are evidences of literature where the osteolysis of the bone in and around, or end plate injury, which cannot be detected intraoperatively by the surgeon per se, could have led to this cage back out or subsidence, resulting into this problem. Now, currently what has happened is this, which is not due to intraoperative surgeon's negligence. I mean, this is what will be brought to their notice, that what was supposed to be done has been done, and today this is the scenario, and I feel this is what is required, and I am hell-bent to do it if you permit me to do so. However, in this situation, with this also, these are my dilemmas. So being absolutely truthful to the patient that this was required to be done, this was done, and this is what is required to be done now, and I am keen to do it if you permit me to do so. With this, I think most of the times patients do tend to agree with you. I mean, you just pour your heart to them, and they will have that empathy to you. They will not suddenly jump on you and play a blame game.
Okay.
Right, Guru, what's your point?
Okay. So just go back to the last failure slide and examination. So I just wanted to make a point that see, the end plates look okay here, and the opposite side screws also look okay. Only the left-sided screws look like cutting out from laterally, and the cage is backing out completely straight. So the only thing is why this cage backed out with screws being intact on one side. So that's one point. And the disc height is reducing. Is there any explanation for that? The disc height was jacked up so much. The screws are intact. They don't look loose on the opposite side. Still the disc height is reducing. Is there any explanation? Because a lot of times we see this, the cage is backing out, but the disc height is reducing. The screws look okay. They don't look loose. So is there any explanation? One is that. So Dr. Rajesh, you lifted your hand for that.
See, one more point, Guru, I want to make just in continuation what you're saying. If you see the posterior margin of the lower vertebra, cage is not backed out so much compared to that. So there is definitely a loosening, a subsidence, and reappearance of the listhesis, which was well reduced before.
Show the
Okay.
X-ray immediate post-op, Bhushan.
Yes, sir.
Okay.
Right? And now if you see, there is a reappearance of the translation, and then the case backs out. So we cannot say it's just because of the fall. And yeah, one more point what Guru is trying to make over here. Whenever you see such things that the disguise is reducing, first thing always, especially if it is beyond 3 to 4 months, that comes to your mind is if there is any kind of hematogenous infection, there are cases which it may appear later on. So here we are grappling with the ideas whether it's a mechanical failure leading to cage back out and pseudarthrosis, or vice versa, or something else happening right from the start.
And also, is there a CT scan for this? Is there a fracture of the end plate that has happened?
No,
resulting
sir.
in screw
No,
cage?
End plates looks okay, actually.
It looks okay.
We don't have a CT scan, sir.
Okay.
End plate fracture, vertical split fracture.
ESR,
Vertical split.
CRP was normal. And
ESR, CRP was
leg
within
pain
normal.
Infection parameters are normal.
Yes, sir.
Actually, when you have such a cage back out in the center, you should always have leading questions for cauda equina.
Correct.
So that is
Umesh,
again very
will you
important.
consider giving a pain block if it is operated by you and the patient is complaining of some pain in the leg, but not much, but she's managing? Umesh Srikanta.
Yeah, no. If this patient comes back to me at an early stage, and you can see that there is a posterior retropulsion of the posterior upper border of the, so there is probably, I'm not so sure, there is some end plate injury that has happened, the upper posterior L5. And this is the happening in an early stage before fusion has happened. It is like taking a risk. If it backs out further, the patient, even though today it may not, he or she may not have a deficit, it's likely that we are taking a big risk by allowing it to retropels further and cause some major neurological deficits. So
Okay.
I would definitely go ahead and revise this.
Revise, not
Even
paste.
if it is even if it is my case. Yes, I would accept that. Yes, something is wrong, and we'll go ahead. And most of the times, though we may not be able to pinpoint the exact cause, most of the times cage retropulsion in the early postoperative period is due to some issue that has happened at the time of surgery. Either it is due to inadequate end plate preparation, there is an end plate, cartilaginous end plate left behind, because of which the cage just smoothly slides backwards. There is a inadequate disc preparation anteriorly, because of which we have actually pushed a large cage under high force. And once the patient stands, increase in the intradiscal pressure, it just backs out and the residual disc pushes the cages out. So I think some issue that has happened, inadequate posterior compression, it is due to some intraoperative issue that cage backout happens in the immediate postoperative period, and we have to accept that. And probably this case, I would definitely go in and revise as early as possible.
Shardul, what problems you anticipate if you are planning to revise? What is the chance of dural tear? How difficult this can be, though it looks so easy, but everything is fibrotic, or the tracks are difficult to maneuver, difficult to identify at times, the dural sac and fibrous tissue,
Yeah.
and suddenly water comes. How easy or how difficult this is for you?
I think it is difficult, like because Rajesh sir told that the cage is quite centric. If it would have been from a lateral, like a T-leaf approach, it is still easy to remove because you get a good space which is not surrounded by any dural structure. So here you will have to make sure that you get through the fibrosis and retract the dura, because without that it is not going to be possible to retrieve the cage safely. So there will definitely, but considering it to be an early phase, it will still be a better case to revise at this stage rather than doing it maybe 6 months later.
Okay.
Because at 2 months, you would still expect less amount of fibrosis.
Himanshu, will you do anterior surgery to remove the cage and fix it?
So I don't think so it is needed in this one because it's a MIS T-leaf. The other side is still virgin and it's a centrally placed cage. So I can go from the other side and probably it will be slightly easy to retrieve the cage from the other side because amount of fibrosis on the other facet would be less. So I don't think anterior surgery is needed here.
Let's see what Bhushan has done.
So we've revised the cage, sir, and we've put in a new cage. We have revised the left-sided screws as well, and we have placed in new screws at the
Nice.
L4, L5 level. And at 6 weeks post-op, patient is doing fine. The radiculopathy and the left lower limb is reduced significantly, but the back pain, she has a VAS of 2/10 still for the back.
The screws were loose and you revised it and you
Yes.
did it properly, and oh, that's a good one.
You went in from the same side, Bhushan?
Yes, sir, same side.
Okay.
The question would be what did you do differently that will ensure that this won't pop out again?
Yeah.
We ensured good end-plate preparations are put in a good graft, and after putting in the cage, we just made sure the cage was snugly fit, and we ensured good compression for the screws.
Great. And Shailesh, would you have gone for a cage for the second time, or would you have just taken it off and put in?
No, I think I would have gone. I think the problem here was the loose screw, which has allowed that cage to back out. And you have revised it, you got a good hold, you have compressed it. So I think this is going to stay for good. But at times, if you are in problem, you can just put a bone graft and just come out. That risk of again the cage back out will be nullified. But
because like at 2 months, a track has been created, so it's
Yeah.
always waiting to come out. And if you see this, I mean, Bhushan, not being critical, it's a great operation and great result. Just that the posterior edge of the cage doesn't look too much anterior. So in this faculty, maybe Himanshu, do you think you would have liked to push this further? We're just trying to be the devil's advocate and
Yes, sir. Yes,
criticize
sir.
our brave surgeons. So
Slightly anterior, most probably.
and
So
would you
just
put
try
in
to, yeah.
a cage or a bone graft, or is there something different you would have
No,
done?
sir.
here?
I feel the disc height was much higher. So just bone graft, probably it would have led up to the stress on the screws and it would have probably backed out again because it's a second track now. So I would have gone for a cage.
Well done,
Otherwise
Bhushan.
also.
Compliments to you. I think we need to move on to the next case. Thank you. Compliments. And let us know after
Thank you,
6
sir.
months, Bhushan, how the patient is doing. Himanshu,
Yes,
over
sir.
to you. The next case. Let's see
Yes,
the
sir.
next surprise. I think it was a very interesting case and well done, Bhushan.
Okay. So I'll just share my screen. Thank you, Shailesh sir and PAS for this opportunity to present my work here. So I will just say that so is my screen visible?
Yes.
Yeah, so I'm just going to say that it's a postoperative leg pain. I won't say why it has happened first. So a simple case, nothing hyphen do. So it's a 48-year-old female, chronic left leg pain and back pain, known case of L5S and grade 2 lytic listhesis. She was operated. It's my so she was operated by for L5S1 decompression and transforaminal lumbar interbody fusion. So I did a regular open L5S1 T-leaf for a lytic listhesis. So this was the pre-op X-ray. It's a mobile lytic listhesis 5S1. You can see it is going up to grade 3 inflection. This is the MRI. Rest of the levels are okay. For her age, for 48, she looks pretty old.
Wait time.
So it's a 5S1 listhesis. You can see the axial cuts. So the pain was more on left side. You can see that the compression on the exiting route is more on left side than the right side. And this is the postoperative X-ray. Standard regular open L5S1 T-leaf. No events intraoperatively. Case went very well. No issues. No dural tear. Drain was put in, so there was no chance of a hematoma. But on next day, morning rounds, patient told that she has severe right leg pain.
So
Now the
pre-op was
patient
left leg pain, Himanshu.
pre-op was left leg pain. Now the patient has right leg pain. When she is lying down supine, the pain is slightly better. As expected, I gave her some dexamethasone, but the pain was severe. So probably for 3 to 4 hours after the dose of dexamethasone, pain was gone. And once the effect of dexamethasone started to wean off, the patient had recurrent pain. The pain was more on changing the positions or side turning. And she was very stable, very happy. Not very happy, but the pain was not very severe when she was lying down flat. Now the pain, if anybody would like to revisit the post-op X-ray, this is the post-op X-ray.
Quick tips, Vishal, what you will do?
Pain more on side turning, changing of positions. Pain is okay
Vishal.
on when she's lying down on her back. Anybody? Rajesh sir, Guru sir? X-ray looks okay. Yeah, Guru sir.
So clearly
X-ray
the
looks
X-ray
quite okay, Himanshu. Yeah.
Is someone there? Yes.
Yeah.
Yeah. But if
Yes,
the
Rajesh,
pain,
please
as
say.
you say, is more pronounced on turning, the
Sorry.
first thing that
Yeah.
always, yeah. Are you able to hear me?
Yeah, yes, sir.
Yeah. So if the pain is more on turning, we always think of instability first if there is any kind of, inadequate fixation. But these kind of situations, when the contralateral pain comes, the first thing that comes to your mind is whether there is any kind of implant issue, any medial threads engaging. Second
Yes,
would
sir.
be hematoma or neural ischemia on the other side. Now, did you remove the rattle completely? That is another thing which comes to the mind because it might force on the other side.
Yes, sir. So
sometimes if you have put too much excess grafts, they can go on the other side. The graft seems to be ipsilateral, not going contralateral, the chances are less. It is also known that if you over distract, that can cause an injury, and trying to give excess lordosis actually reduces the size of the foramen on the opposite side. So that
absolutely.
can also be there. So based on the pain, you decide whether you want to just continue your medical management or do the re-imaging. Re-imaging
Okay.
would require MRI and CT both. So DEXA you have started, wait for 24 hours in the absence of neurological deficit, mild to moderate pain. Severe
Yeah.
pain, do the imaging and then take a call what you want to do.
Okay. Yes, Guru sir.
Okay.
To say something?
So can you just show me the pre-op X-ray?
It's not a very great quality X-ray.
Yeah.
It's done somewhere else. Yeah.
So see, this is the thing. Y- uh, it's what severity is it? Opposite side.
Severity is more than pre-op. So pre-op leg pain, so probably it was VAS 6. Now the post-op opposite leg pain is VAS 8.
Okay.
So the
So
severity has
basically,
increased.
with this kind of collapsed disc space with a kind of lordotic listhesis, when you reduce, you can have opposite side leg pain due to stretch.
Okay.
So if it is, I would do certain things like whether she's getting any relief with knee and hip flexed, relaxing the
So yeah, I
basically.
tried that. So I made her sleep with a bolster below her knees. So there was some amount of relief, but it was not very significant.
Okay. And the other thing is, I would see for SI joint tenderness and
Okay.
favor.
Yeah.
Favor. And if at all I feel favor and SI joint tenderness is positive, I would give SI joint block.
Okay.
So that lot of times that takes care of these pains, opposite side
Okay.
leg pains.
Okay.
And
Especially at 5S1 listhesis and fusion.
yeah,
Okay.
especially with L5S1 listhesis and fusion.
Okay.
Mostly it is due to stretch. You just reassure it settles maybe in 2 weeks to 2 months time, but
Okay.
that's the issue with it.
Okay, sir.
I think
Okay.
if I may say,
Yeah. Yeah.
if you have not done the opposite side decompression, have you taken the rattler out
Yes, sir.
completely?
It was a standard midline surgery. So complete rattler was taken out. Bilateral exiting routes and bilateral traversing routes were made free.
Still, what happens in in this kind of reductions where you are trying to reduce it and regain the height of L5S1 with the cage, there is a
Yes.
chance that the root can hit the wall of the exit. Okay, at that level, we have seen some amount of stretch
Yeah.
which can come. That curvilinear area where the root passes by, that becomes stretchful and it causes significant pain. So I think that is probably the culprit, or some bone graft piece also can contribute
Yeah,
to that.
it can actually come back and hit the
Second
root.
is that, and always check that medial wall or inferior wall, any thread is hitting the root.
Yeah.
If it is, the CT is important. You need to check. Hematoma, of course, you need to do the CT, MRI, immediate CT and MRI. And hopefully there is no deficit. So I think if it is not settling in 2 days or, that severe pain, you need to re-explore.
So,
Okay.
Shailesh and Guru, can I ask you what's your threshold to do investigations? Himanshu gave the patient steroid and the patient was better in 24 hours. So, at what point will you say go home, and what point will you say no? I need to wait you down and get MRI, CT, whatever.
No, I think very rightly asked, the question is very important, because if the patient is feeling better with steroids, and even if that pain threshold, if it is 8, it goes to 6, and maybe it reaches to around 4 in 2 days time, I am quite okay. If it is not settling and you are needing constant analgesic requirement and steroids, I think that's not a good idea. We need to investigate.
So, improvement with steroid, go home. No improvement, investigate.
Absolutely,
Guru,
yes.
any difference of opinion?
Yes. So I would see whether the pain is there at rest or with mobility. If it is at rest, I would definitely investigate, because that is a sign that there might be a screw impingement on the root. And if this also depends on patient's mental status, how patient is irritable, how sensitive is the patient.
Yes.
That matters a lot. And the next thing is whether patient has any new paresthesias or any new numbness. If motor deficit, definitely yes. But then if there is any paresthesias, numbness, constant tingling which is happening, which indicates root irritation, then again I would investigate. These are the three factors which really matters whether I would investigate or not. Yeah, and I wouldn't basically, if at the time of discharge, if patient is not saying that I'm little better than what it was, then again, for medical legal purposes, before sending home, I would definitely investigate and send her home.
Okay.
That's great. Himanshu, isn't there always a battle in your head that if I don't investigate, someone else will?
Someone else
How
will,
do you
exactly.
deal with that? Yeah.
So I always feel that if the pain is persistent, if she's not happy or satisfied with whatever responses she's getting from me, probably she'll go somewhere else and get investigated. There may be a malposition screw or anything. So
How many of you will consider giving a pain block for the right side?
after the MRI, if nothing is there, I would consider that. But after the investigations.
Okay, let's see what you've done, Himanshu.
Okay, sir. So just before going to so this is the post-op X-ray. So before going to what happened, so whoever is listening to this, for the audience, I just want to state a couple of points regarding the anatomy of the 5S1. So L5S1, if you see, inherently they have different canals. So L5 canal is very different, or the lumbar canal is very different, and the sacral canal is very different. So you can see the sacrum, the S1, S2, they have a trifoliate canal. So you can see the difference between the shape of the S1 canal and this is the L5 canal. So L5 canal is kind of oval or circular, not exactly circular, but kind of oval. S1, the shape changes completely. It's a trifoliate canal. It is never a circular canal. So if you can see anatomically, So this is the L5 canal and this is the S1 canal. So it's a very classical trifoliate canal which is there at the S1 vertebra. So if you can see, you can divide that trifoliate canal into left flange, right flange, and the central area. And when you're putting a screw in L5, even if your screw is slightly medial, that is still okay because your canal is central or oval. So your medial screw is not going to enter your canal. On the contrary, when you're so you can see the rootlets are there. If your screw is slightly medially placed, that is still okay. It is still inside the pedicle. It is not going through the canal. In S1, if you are slightly medial, so it is going inside your canal and it is going to irritate your root. So it's a trifoliate canal. So you always have to consider the anatomy while putting a screw. So you always have to take that into consideration. So here you can see the patient was not better. So I got the probably the happiness index after DEXA for the surgeon was very short lived because in 4 or 5 years he started having pain again. So that happened for 3 doses of DEXA. So I got the CT scan done. So it was a slightly medially placed screw. Probably it was not through the root, but you can see it is breaching the medial wall because it's a very nicely placed trifoliate canal. So it is entering the flange of the trifoliate area. So you can see it's a slightly medially placed screw. So that's why she was getting an irritation while turning on right side and left side. So there was an irritation of the screw and that was a mal-placed screw. So I had to go in. So there was a lot of explanation which I had to give. But one thing that we always do is we keep the drain inside and so you can tell the patient. So this is a practical tip taught by one of my mentors. So you can keep the drain inside. If the drain is stuck inside, you can go and take out the drain and you can revise anything that is there, which is there inside. So this was a day 3 revision. The patient was a low demanding patient. So I went in, revised the screw, everything was okay. So the point which I wanted to make through this case is you have to always consider the anatomy and you have to learn the anatomy before entering into entering into spine surgery. So you have to know the anatomy well. So S1 you always have to check for the extent of appendages. It is a trifoliate canal. In some cases, L5 can also be a trifoliate canal and you can do this kind of injury to the nerve root. And the placement of screw interop is very necessary. So know the anatomy and then start putting the screws. So this is the lesson to all the people who are newcomers into spine surgery. Thank you. So I don't have the image of revision of the screw here, but I think the message is driven home.
Yes, Shardul, any takes from this?
No, I think like all have discussed, we need to investigate if it's not working the dexamethasone and steroids. And medial placement of screw is something, even if there is, I think there are a literature which they say that you can still wait and give a nerve block, I guess, because it is just a grade 1 medial breach. But
Yeah.
I think if the pain is severe, it is better to go in and just revise rather than having a sleepless night for 6 weeks and also the
Absolutely.
patient calling you every time that there is pain, there is pain.
How much will you wait, Dr. Nene?
More than that, I think how would you counsel the patient? How would you counsel the patient that I've fucked up? My screw has gone, into
So in
the
my
canal.
case, I was pretty lucky that it was a low demand patient, but that may not always happen.
Yeah.
But I think it's important that we tell them that it's an intraop error.
Yeah.
And you, again, like Vishal said, you go through all the steps with them and tell them that and they understand it's a human error and they are most grateful, at least in my experience, because I'm a master of these complications. So in my experience, every time I've had a complications, if I've been absolutely 100% transparent, they appreciate it and they are happier that you've addressed the issue and you tell them the benefits of addressing the issue at this point, including cost and including lack of suffering and everything. And that the primary surgeon is getting an opportunity to do this rather than a new surgeon coming in. And they would appreciate it. As far as how the question was, how long would you wait? I think, a couple of doses of steroids if the opposite leg pain is not going away. I definitely investigate. And if investigation shows there's a medial screw under some pretext or the other, I would want to go in. I have a trick. I normally counsel patients pre-op that one of the complications is hematoma. And in this case, if you did a post-op MRI, it would certainly show some hematoma, which would be reported, and you could use that as the excuse to go in and replace your screw because this malposition may not be out there. So if this patient had shared this report with his colleague or his relative in Delhi, they probably may not have been able to identify that it's the screw, and life would have been easy for you as a surgeon. This is just a practical tip.
Vishal, a question for you. There is a problem. Now you have seen the screw, you remove the screw on table. Is Vishal around?
Yes, very much.
And you're trying to put the screw, and there is a lot of, it has become a wide hole, and you are not been able to put even 7.5 screw at S1. What is your next step? Will you just consider just removal, or you will go to S2 AI, or or you will still try extrapedicular route, some amount of stability to the S1 screw from extra lateral approach?
So before I answer this question, which is a very, very pertinent question, Dr. Shailesh, can I just add on to Dr. Abhay's comments of what he just mentioned?
Yes.
Because on one hand, Dr. Abhay just mentioned on what is to be done. I think I have also learned from him, because he's been my mentor and all my colleagues have taught me and all our bosses have taught this. What is not to be done strictly while communicating with the relative? One is, if this patient is mine, please don't get offended. Sometimes we try to hide. Sometimes we try to lie. Sometimes we try to cover up. Sometimes we try to do the blame game. It is absolutely worth it to just be honest to the patient. And believe me, the moment we start hiding, no matter how confident we are in hiding and lying, most patients will either gauge it now or at some date later. And that day, this lie when caught is very, very nasty. I mean, they can really then come back to you. And if somebody else has caught your lie, for example, this patient goes for a second opinion and somebody has caught this lie, which is the actual true thing which you have lied about, then a medical legal scenario can appear very fast. I mean, they will get very upset that my doctor whom I have been trusting has been lying to me. That is one. And second is, if this case is not mine, has come to me after a surgery by some of my colleague, I think the one thing that we should not do is to criticize the colleague. I mean, to blame it on the colleague.
Correct.
That
Yeah, it
he
can
has
happen
did a
to
wrong
any
thing.
tomorrow. It can be your day. Yeah.
I mean, this is something that we must. I think I have learned this not only from Dr. Abhay, but Dr. Ram, Samir, Gautam. Everyone has been teaching this very often, and I strictly follow this, believe this. And if there is a complication of one of my colleague, even whom I don't know, even if it is from an orthopedician, or even if it is from a neurosurgeon, or even if it is from the most junior guy,
Absolutely.
saying that the surgery was done wrongly,
it's a very important message, Vishal.
so using a word which can blame that guy or pin that guy will not only put him in a place, but it will also put you into a spot.
Absolutely.
And it's something that one must not do for sure.
Yeah.
Now, coming back to your question. So if we are doing a redo of this screw which is there, and while in an attempt to reposition the screw, if we have created a big hole, bogda, khadda there, then I would say that don't put the screw on that side. Whether you want to do a reconstruction by using a S2 iliac screw, or you are doing a Ayler screw, which is just diverging the screw towards the sacral ala, is purely based on the purchase that you get. In a young patient, I would refrain from going to the ilium. I would rather do a sacral ala screw, but remember that putting a screw in the sacral ala laterally, I mean the screw which is diverted laterally, it requires a completely different set of expertise. These are short screws, they are divergent screws, and one must be very, very confident in putting them. And even if you have got a good purchase in that, you must ensure that this time you have got it right. I mean, the purchase should be really strong.
Yeah.
Because this time intraoperatively, first time you were conscious, this time you should be conscious and confident before you come out. And this purchase, if you are not able to get on table, one, you are confident to put that screw. Two, you have consciously did the right thing. And three, you are confident after putting that screw that yes, it's got a really strong purchase. Only then come out. Otherwise, just go and do a iliac screw. It is absolutely not a matter of shame while you're doing a revision to extend your instrumentation from one level to another. And remember, when you're doing a revision surgery, the consent should mention always, because this can happen to the most expert hands, even when you're using a navigation, even when you're using a O-arm, that your screw may not really have a good bony purchase and you may have to extend your instrumentation from up to down. So pre-operatively being mentally prepared, documented, spoken to the relatives, and then going in and then being conscious and then confident, and only then close it.
You said it right. You summarized very well, Dr. Kundani. I think it's a brilliant case, Himanshu. A lot of learnings for all of us. And we move on to the next presentation by Rajesh Parasnis. Rajesh, can you please upload?
I will. I'll just run through my case, Shailesh, because, it's something similar.
No problem. You can just run through. We have a couple of cases. We can discuss more.
Are you able to see?
Yeah. Yeah, it is come on the screen.
Right. So I'll just run through, I'll cover points. Abhay,
Yes.
Shailesh, everybody, Vishal, you are most welcome to intervene and ask questions.
Yeah.
Sure,
Right.
sir.
I have a couple of cases. So something similar to what Himanshu has shown me over here.
You operate
Yeah.
patient for the leg pain and you get pain in the opposite side.
Right. So this was a 58-year-old gentleman, grade 1 listhesis, lysis, unilateral symptoms, claudication prior, radiculopathy now, also AHL EDL weakness, nothing on the opposite side. This is the preoperative imaging. It shows a collapsed disc with grade 1 listhesis, a pseudo disc. Also, the the actual images can clearly tell you that the foraminal stenosis is mostly on one side, the right-sided symptoms, left-sided not so much. So the decision was, this was 8 years back, to do a T-leaf. Those days, Indian instrumentations may not used to be, not available for MIS. So this was an open T-leaf, went on smoothly. We retained the rattle, we decorticated as a bone graft. We put a cage over there, which was a PEEK cage. The same evening, he started having opposite radicular pain. Severe pain even at rest, no relief even on knee flexion, just mild. With 1 or 2 doses of Dexa 6 hourly, next day morning also, he did not have much relief. Now, when it comes to ipsilateral pain, when the surgeon himself knows what has gone around, you can have a larger threshold to do investigation. Contralateral, at least I have a very less threshold. I was not worried so much about the implant, but because I had retained a rattle. So this was the imaging. The MRI did not show anything much. So also the CT, but since the rattle is remaining, you can see one is not sure about the opposite-sided foraminal space. Now, this is not something I used to do very commonly to retain the rattle. And since that was bearing on my mind, plus the pain was very intense, and the hyperesthesia and sensory symptoms also worsened in 24 hours, that time we decided to go in. So any questions, any discussion so far?
Rajesh, the decision to go in was based on clinical judgment or based on radiology?
Three things. One is not much relief with Dexa. Second thing is pain being severe. Third being, I know the family personally, that also must have been bearing on my mind. But rather than waiting, I decided to go in because there was not much pain relief.
So
Now, if I
basically,
really want
clinical
to,
judgment, you did not have a target in mind
absolutely.
when you go in. So is that a message you will give out there? That if you're clinically
No,
convinced that the pain is significant and of coming from a bad place, even though you don't find a target on radiology, you would rather go in?
absolutely. I mean, the point I'm trying to make is radiology every time may not make you wiser. Okay. Second
Vishal,
thing is, when
Vishal
it is
has,
your own case, when you have operated, you have an insight and you are apprehensive about certain things. When you know that you have done everything that could be, that you have done, or there could be some lacuna. Now, here I'll tell you what had happened. The rattle had moved and rotated a bit because of the, the tulip of the opposite sided L5 screw. And when it pressed, because the lysis were very close to the entry side of the pedicle screw, that had sort of created impingement, and it resulted into the nerve impingement leading to this persistent pain.
Let's see what Dr.
Now,
Apaji Krishnan has to say. Apaji.
Sorry, I joined very, very late. I was in a meeting.
You will, Apaji,
Yeah.
you can give vote of thanks at the end of it.
I
okay,
know,
so
Vishal.
Vishal had raised his hand and Guru
Yeah,
had raised his hand.
Vishal. Yeah,
Yeah,
Vishal,
yeah. Let
Apaji.
them
I
do
think
that. Yeah.
I just wanted to bring out this fact that maybe because Dr. Parasnis had an emotional connect with the family, that he was very, very emotionally linked to the family, that he decided so fast to go and intervene, because post-operative contralateral leg pain in a patient after instrumentation is known to happen because of certain fixed reasons, out of which one is reduction of listhesis causing a narrowing of a previously asymptomatic narrow foramen. Similarly, compression on the both sides. Once we put an instrument, we generally, all of us have a tendency to compress. So if you have not jacked up the foraminal height and compressed it, then the asymptomatic narrow foramen on the opposite side can become further narrower in particular cases where you've done only one-sided decompression or the symptomatic side decompression. And third, sometimes in patients with lytic listhesis per se, where there is granulation tissue around the lytic listhesis, which is also one of the causes of impinging on the opposite side exiting nerve root as the cause of pain. And of all these, the only one which actually requires immediate intervention is where the foraminal height is further narrowed because of your compression. The other cases where the narrowing has happened because of reduction of listhesis or because of the granulation tissue, they eventually, even literature has proven that they eventually settle down unless there is a frank neurodeficit immediate postoperatively. So I'm just putting a point forward. I'm like Dr. Rajesh said that this cannot be a generalized rule.
Yeah.
That in absence of radiology,
But I think
going and
Vishal,
intervening may
sensory
actually worsen
deficit,
the situation.
do you consider sensory deficit also significant or only motor?
Both. I mean, I would consider that only motor deficit is the reason where I would immediately intervene. Otherwise, without a radiological gross difference in foraminal height or a compressive element, intervening without a obvious evidence, really whether it will really help my patient post-operatively, I will be really doubtful. And how would I justify my patient if it doesn't get better after the surgery? In this case, your case, because you knew the patient, you were able to take them in confidence. That matters a lot. Like you just mentioned, your justification was because you were emotionally connected to them. They had immense faith on you. They trusted you blindly. But I think these things matter a lot in your decision about going ahead and doing a surgery. Just imagine this patient not really, being in gross good faith with you. They are absolutely angry about the outcome post-surgery, and you go again, and the patient's post-op pain doesn't goes away. That patient will screw your happiness if he is not really in good trust with you.
Yes, Apaji.
Yeah. So I agree with Vishal. So the contralateral leg pain is a known entity. Literature review says 7 to 11%, and 95% of the time they are irritation, as he said, jack up. There may be a traction, there may be a narrowing. So if there is no telltale evidence or a neurodeficit, there is no point in intervening immediately. Usually, we should differentiate between a radicular pain or if the patient has hyperesthesia or dorsal root ganglion compression. If there is hyperesthesia, then do a CT scan, look for your screw malposition or compression of the root. If nothing is there, there is no point in intervening. Thank you.
Shailesh, I have just put up a slide which summarizes our approach most of the time.
Yes.
Yeah, and all the senior stalwarts have put in. So if the time permits, I'll just 5 minutes to run through the other case.
Yeah. Rapid fire.
Hi, Shailesh?
Yeah, you can go to rapid fire one case.
Yeah. So this was a recurrent disc prolapse. Okay. 38-year-old male, classical radiculopathy of 2 months duration, tingling, numbness. He presented to me with persistent of pain. This was his first MRI prior to the first surgery, following which endoscopy was done. This was the second MRI, which still showed, and you can see the contrast MRI images lower down. There seems to be a large fragment over there. His pain had worsened. 6 weeks down the line, he was not able to do most of the ADLs. VAS score has worsened. Not much relief with conservative. So any comments, anything right now? 6 weeks post-op, a large fragment seen.
Dr. Rajesh, you said contrast MRI, we can see the big fragment, but then that enhancement cannot be disc, right?
Yes.
So that enhancement cannot be disc.
Yes.
So I don't know
so
whether
post-op fibrosis, vascularity, all those things. The enhancement disc, if it is separated from the parent, it should be avascular.
Yep.
Right?
So yes, but even if it is connected to the parent disc, the disc will not enhance at all.
So disc with avascular, and it will have a ring-like lesion.
Yeah.
Because
so
of the
enhancement surrounding. If it is uniform
formation,
enhancement, it is not a disc fragment. It is just granulation tissue.
Yeah, granulation. Yeah.
Yep.
Right. So this patient was also given a root block after this. Still had persistent pain. Still came back. Okay. And my colleague did a microdiscectomy because I had usually my threshold again for revision. When I am doing my revision surgery, threshold is low. If somebody else has done, it's very high. Right. So he underwent a microdiscectomy at this level. Now he again comes back after 6 months. He had a good relief for 6 months. Some query history of lifting weight, pain on sitting and movement this time. His pain was more on activities, not so much on previous walking and standing, but something like getting up from sitting, getting up from lying down position and turning on sides. Unable to work. Not much relief, he says, with rest and medicines. This was his post microdisc, post 6 months, and this is the scenario now. Now, this guy was short, squatty, high BMI, and this was the picture right now.
X-ray, flexion extension X-rays?
Not much change in flexion extension, actually.
I think there's a pars lysis.
Query unilateral,
Yep.
but the imaging did not confirm it. So maybe the microdiscectomy side on one side, it was too lateral, or just a facet to overshadow.
Because if you see in extension, it's going into retro, and in neutral and in flexion, it is aligned very well. So
Yeah,
there is some kind
could
of
be
yeah.
some mobility, some instability for sure, but whether it is just because of lysis, very difficult to comment.
Yeah, definitely.
Yeah. So here it did not show any kind of, the usual MRI shadows that you see around iatrogenic lysis, nothing like that. Now, persistence of symptoms, not much relief, high demand individual. What would you do at this stage? Everything has been tried. When the repeat blocks suggested, he said once in the past, it didn't help. What is the point right now? But do something. I'm not able to work. Already my insurance is getting exhausted. My leaves are over. This is going on since now almost 8 months.
Unilateral
Anybody?
leg pain? Unilateral leg pain?
Back pain and unilateral leg pain, but back pain also spreading to both sides, also to sacroiliac regions. The sacroiliac pathology ruled out on imaging. We did a scanning. So this was more like instability. And going through the notes of the microdiscectomy, it had a lot of blackish eschar tissue coming from the disc, because this was a discectomy at a time when laser was used quite a bit. So they had sent it for histopath. That's how we got the report with the notes.
Fusion.
So would you treat this as an instability situation now, 2 times operated, younger individual who wants to be active? Or is there anything else which comes to your mind? All the blood parameters were within normal limits, CRP marginally raised.
So if it's really troubling him, he is not able to pursue his occupation, day routine activities. So it requires a long discussion with the patient. If patient is ready to understand that we are going to try something which we think which might help or which might not help, if he is ready for that, then you can go ahead and do a fusion surgery.
Right. So what helped here in my favor was patient took second, third opinions. Already mine was second. And thankfully, with the big city close to Pune, somebody advised fusion surgery. So he came back saying, I'll get operated in Pune only. So I did his fusion. This was the subsequent second MRI because no relief. So here, if you see a lot of track shadows and edema around disc edema, no sign of infection. Again, no sign of lysis per se, but a track. And this is what we did. Thankfully, the patient 7 to 8 years down the line is okay. Last year, he came back with pain and we looked for ADD. It's not there. He did well. So the disc herniation can happen with any technique. It can happen with micro, standard, lumbar, endoscopy, UBE, anything. Till now, the literature says that the recurrence is in the first 6 months highest, then it drops down. In the first 6 months, it could be 12 to 15%, later on 2 to 4%, on an average between 5 to 12% for microdisc, 2.3 to 13% for endoscopy. These are the high risk factors that you can look for. Then there are various studies which tell you how many symptomatic, asymptomatic. Every recurrence need not be fused. Yeah. Now, there are reasons why it happens in the first 6 months. We all know this. Now, few, things to see on the MRI, because post-op MRI reporting is not that easy even for radiologists. So interpretation is also not that easy as a surgeon. So don't be aggressive in going in. There could be a lot of things like that contrast MRI showing just a fibrosis, and reoperating may not give them good relief if you're not sure what is the initial diagnosis or confirmed diagnosis. So these are the things to be seen on MRI. Sorry, I'll just run through. Don't have. So there are contrast MRIs when to do what. So there is not much, evidence still today to say that every time you revise, you go for fusion. Not much significant difference in terms of radicular pain relief outcome. But definitely the satisfaction when it comes to back pain and fusion giving more stability, it could be better with fusion. So yeah, this is what my message was, that no particular technique today is a panacea. It can happen with any techniques, and we have to be ready for recurrences. But every recurrence does not require revision surgery, and every revision need not be a fusion surgery. Thank you so much. Any comments?
I think it was a very interesting case, and though it looks like a simple surgery, I think disc can be challenging, can be nightmare at times, and it can happen to any experienced surgeon. We have to be careful. Patients' counseling is important, and it is very, very important to explain why it is happening, and if it is done by someone else, still you have to be sympathetic because it can happen to anyone. It is not that anyone has a God's hand. It is very human to have this kind of recurrence, and there is a lot of literature. Thank you, Rajesh. I think we move on to the next presentation by Dr. Umesh Srikanta, and then the last one by Dr. Gururaj. We are going very on good time. Over to you, Umesh, for your presentation.
Just give me 1 second. Exiting is again a problem. I don't know how to unshare this. Can anybody help me over here?
The OrthoTV team. Anyone around? Himanshu, Bhushan?
Will it help if I leave and rejoin?
Yeah,
It will be easy.
that will help.
No. I think. Can you see my screen now?
Yeah, we can see.
We can read all your emails.
Lot of invites to you from all over the world, Umesh.
And lot of money in HDFC bank account.
Okay. So I think now you can see the presentation, Allah?
Yeah.
We
can see.
So this is a case of early recurrent disc herniation, and so this was the initial presentation. It's a 47-year male manual laborer, chronic low back pain, exertional, and he had a recent worsening left lower limb radicular pain, predominantly L5 distribution, 3 months. And he tried physiotherapy, medicines, rest, no significant relief. SLR was positive, no deficits, just a routine. As you can see in the MRI, there are some mild end plate changes on stir sequences, whereas there is a around a grade B disc protrusion at L4-5, predominantly on the left side, lateral recess, along with some end plate changes, as we can see. So this is the axial sequence at the upper disc, mid disc, and the lower disc level. So this is the main herniation, broad-based protrusion, both central, left paracentral, significant compression on the left traversing nerve root, mild ligamental flaval hypertrophy, not significant facetal hypertrophy. And so this was X-rays, flexion extension did not show any instability. And, as a routine case, he underwent a left L4-5 tubular discectomy with a 16 millimeter tube. During the surgery, we felt that it was uneventful. There was no critical event. There was no, incident that we could think that it was abnormal. There was initially a cruciate annulotomy was done. There was a moderate sized disc fragment. A large subannular defect was found, and the loose fragments were recovered from within the disc. We don't have a video, unfortunately, intraoperatively for the first case. Patient postoperatively recovered well. Radicular pain subsided. First post-op day, routinely as discharged. But unfortunately, the moment he went home, he says that the moment he went home, he started developing leg pain again. That is on the first post-op day. By the time second post-op day, he had some significant pain. He waited, but he came to our OPD after 5 days from the initial surgery with recurrence of severe low back pain, so severe lower limb pain, predominantly again on the left side, but again involving the right side as well. And he had difficulty in walking. On examination, he had left EHL around 2, left ankle dorsiflexion 3, perennial hyposthesia was there. However, he was able to void urine. And in the presence of a neurological deficit, we decided to go ahead and investigate him immediately. And unfortunately, this was the sequence. This was the image that is seen. So again, as we can see, there is a huge, this is just a week from the first surgery, there is a huge, massive recurrent disc herniation, which is extending both superiorly as well as inferiorly. So axial sequences in the center, as well as, mostly central as well as left paracentral. There is a significant compression on the thecal sac as well as on the traversing nerve roots on both the sides. So the first question that I would like to ask is, what could have gone wrong? Because intraoperatively, at least we weren't able. We went back. We thought during the surgery. We asked our assistant who was there, and whether any unusual thing was found. There was nothing there. We actually went through the video on the microscopes, because it is stored for a few days. So we went through the microscope video. We couldn't find out anything significantly that wrong or untoward event that has happened during the surgery. Now, of course, early large recurrences are known, but just for the sake of discussion and the audience, probably we can highlight what are the points that could have gone wrong during the initial surgery, which has led to a significantly large and an early recurrent disc herniation.
Hello, Umesh,
Yes.
can you hear me?
Yes.
Yes,
Yeah.
we can hear.
So did you have any ossification of the annulus?
No.
No. And actually, if you observe here, I don't know whether it is of any significance. There is an anterior disc prolapse also.
Yes, there is an anterior disc prolapse.
So which is very, very
There is
rare.
an anterior disc prolapse even in the recurrent.
Yes. So it's a very, very rare thing. You have an anterior disc
Even
prolapse.
in the recurrent, it has increased.
Yes.
It has increased compared to the first scan.
Yeah.
Even in the repeat herniation when it happened, it has increased.
So I feel,
but our preoperative.
I feel this was there was some kind of instability here. That is why it led to such huge recurrent disc.
So this was a flexion extension standing preoperative images.
Shailesh, since you do endoscopy, what is your take on this?
I think this is not very commonly seen, but at some times what we have realized that we remove the extruded fragment or the fragment which is come out and we palpate, but at times there can be a larger disc, and especially in maybe early infection, we have seen a large disc coming out at a couple of weeks' time from the primary index surgery, because that is very characteristic of having some early infection. But this is not so common. You can get the recurrent disc, but not such a huge one. Very, very less chances, but it can happen.
Umesh, what was your hunch then?
So we of course, we had to do something for him because he was already having a neurological deficit. But, more than anything, we were worried about how it happened and whether we are missing anything. One thing that we considered was whether there was any instability, but there was no instability. Second thing we thought was whether there was any infection, but it is too early. 5 days is too early even for a post-operative infection to come back with some, again, we were actually baffled. We were also looking for answers, and I'm not sure that we found any conclusive point to say that, okay, this could probably the reason why it has happened. There was a large subannular defect, and probably that was one of the reasons why we thought is, probably there was a lot of soft component inside the disc space, which was not completely removed, and immediate post-op, because of the large defect, it had, it prolapsed again. So that was the only logical explanation we could come up with. I was just hoping that any of you could put in some thoughts or put in some light on how or why this can happen so immediately after the surgery.
We always talk about how much to remove, because that's a pertinent question in endoscopy, micro discectomy, or open surgery. But at times when we do get a large fragment in the initial surgery, we feel that, this is a big extrusion. And normally you try to check, is there anything? But if you carefully see, you palpate, and at times you can use a nerve hook. Sometimes in the mid-age or elderly, you can definitely see some amount of, disc fragments coming out. We normally give the disc wash we used to give before endoscopy, and it used to get some amount of disc which is remained. Nowadays, we are using endoscope and there is a lot of water flowing. So that thing is already sorted, but still it can happen. A hidden fragment can come out.
Yeah, I understand. I think all those points makes absolute sense if we are dealing with a residual disc herniation. But this is not a residual. This is this disc is much bigger than the original disc itself. And this is something that has increased after the surgery. It is not like a fragment that has been left behind. Compared
I think absolutely this is very, very uncommon. We have published one editorial on residual, recurrent, and retained disc. At sometimes, supervised neglect what we do. We palpate it, we feel that it is there, but we feel it will not come out, and that's a retained disc. It's not recurrent, it's not residual, but it's probably at, if there is a L3-4 and L4-5, two discs, we normally see larger one is 4-5, which is the culprit. Clinical correlation is 4-5. We see the root above, we decompress the root and we don't take the disc out. And that disc comes out after 15 days or 1 month. That's a retained concept. But here you already done a discectomy. Probably a hidden fragment, which is a loose fragment, and we couldn't. Sometimes this can happen to anyone, and it is untapped fragment which we couldn't remove, and this can happen.
So the other thing which is notable here is end plate defects. There are multiple end plate defects, so which actually shows there was some robust avulsion, robust end plate avulsions which have happened.
Maybe when you remove the disc next time, did you send it for the histopath and culture?
So your end plates are wavy and they have defects, small snodes and all that.
No, but these kind of defects we observe very commonly. End plate changes, modic changes, small snodes. We observe very commonly, and I'm not so sure that means in all those cases there is any evidence or even literature wise to say that in the presence of modic changes or small snode or an irregular end plate there is a high risk or an increased incidence of a recurrent disc herniation, or especially an early recurrent disc herniation.
Okay. Yeah. Anyone to put any lights? Appaji?
Appaji will come for vote of thanks only now.
Okay.
No. Yeah. So acute 5 days disc prolapse. Only thing which I can think of is it was an ongoing disc prolapse when they were doing the intradiscal exploration through a defect, would have loosened more fragments, not removed, and they have come out. And with the modic changes, even in the preoperative, the disc will be loose, the end plate is inflamed. They can just was this cartilaginous when you removed Umesh?
The second time, it was a little bit of cartilage.
Cartilaginous, yeah. So they come out with the end plate and then prolapse. If you see modic changes, acute disc modic changes, the cartilage is usually loose and they can come out. It is. I think Ganga Hospital has a paper on this.
Okay.
So what is the recommendation? Like we see a modic type disc change, modic changes in the end plate, and we are dealing with a disc herniation. We are doing a microlumbar discectomy. Is there any different strategy that we have to employ in the presence or in the absence of modic changes?
If we are, exploring intradiscal, remove whatever is coming out with your forceps, not with your hook.
Okay.
All right. So now again, coming to options. So what is what would you like to do? So like say whether we do a redo discectomy, because even now I didn't show the X-rays. We repeated the X-rays, of course, after the second one also, and there was no instability in that. Whether to do a open.
Umesh, here I feel now if you see Obviously, the disc has come out. That is why the disc height looks smaller. But there will be a
Yes.
vertical instability here,
Yeah.
which you don't see in the flexion extension X-rays, which you will see actually. Where is the X-ray? Standing X-ray you have? At second surgery, second
No,
after the
second
recon.
surgery, no. So if there was a vertical instability in the first instance itself, the difference between the supine, we always look for it. Even for OLIF cases also, we see the difference between a supine MRI and a standing X-ray. The disc height that changes if there is any vertical instability. Here it is not.
So the
You can
thing,
see that the disc
why
height is
I feel is
maintained on a standing flexion.
your ALL is deficient, your PLL is deficient, your disc is deficient. So there has to be some instability here, which we are not able to actually elicit. Because all the ligaments are gone. ALL is gone. There is anterior disc prolapse. There is a posterior so massive disc prolapse. Disc height is reduced.
Yeah.
No, anterior disc prolapse means, at least I don't think it is so rare. Means we see we do see anterior disc bulges, and the fact that anterior osteophytes are so common itself says that there is a incidence of anterior disc prolapses as well for in a degenerative spine.
I think for me,
but I understand. I completely agree that yes, it is not very common. Yeah.
For me, it will be fusion. You do MIS or open, whatever.
MIS still if.
Yeah, I too agree. A fusion surgery. Yeah.
Yeah. So that is what we did. So intraoperatively, we did not find any end plate defect. The disc was not inflamed. His CRP levels we did. Of course, we suspected, as I mentioned, we are suspecting infection. His CRP was borderline high because it was around 1 week after the surgery, but it was not significantly elevated.
Okay.
So I think this is what was done. Yeah. Thank you. Any other points to be added?
I think perfect execution and challenging case and a lot of discussion. I think we need to move on to the next presentation by Dr. Guru Raj, and we will have the ROL by Himanshu. Guru Raj.
Okay, can you see my screen?
Yes.
Okay, if you can see, then I have to. That is happening. Okay. Okay. So 44-year-old male, a very active male, a trekker who actually takes people on treks, and comes with low back ache, severe low back ache with bilateral lower limb radiculopathy, mainly left more than right side, and not walked properly without support since last 3-4 months. History of spine surgery for L5S1 PIVD in the past. So he had failed conservative treatment, underwent L5S1 endoscopic discectomy around 2023. Symptoms recurred in 15 days. So I don't have the previous images. Symptoms recurred in 15 days and again did a endoscopic discectomy. He had a symptom-free duration of almost 2 years. Now again, he has a similar symptoms. So that's the MRI. So what next? So 2 years symptom-free period, L5S1, already operated twice. Anyone?
Umesh, maybe you can take this up because it's endoscopy.
It's a no, irrespective of endoscopy or whatever that original technique was, it's a third time recurrence, and I would definitely consider a fusion procedure.
Yeah.
In case if we are planning to intervene, it's a third recurrence, and I would definitely offer
So,
fusion in this particular
Umesh, do you
case.
feel at the first instance when the surgery was done just
If we
after
have
15
if we
days?
have the images,
No, we don't have
if
images
we
of
have
that
the
time.
images,
We don't have images of
yeah.
that time. So, do you think that was a recurrence or that was a retained or a residual disc at that time? They had to go back just within 15 days.
Now again,
No,
without the
probably a lot
images,
of
I'm
time.
not sure.
Yeah. But still, a lot of time, a surgeon feels that I have done a good job, and we don't realize at that time there can be a residual disc. And if you're not given, the real discectomy is after you remove a large fragment, you should check. You should be patient, not to close and come out fast, because you may miss, and that is very, very important for anyone, a younger surgeon or a senior surgeon, not to rush and go for closure. Always palpate and see, are we missing a disc fragment? And that's a residual disc, I always feel, can be a culprit. Probably it is there, or a recurrent. Recurrent is definitely more common than residual, but there is a possibility of a residual in the
Okay,
first.
Dr. Nene, will you do discectomy or fusion?
So I think I'm heading towards a fusion. It's been too many times that you've had a go at this guy.
Okay. Anybody would do a discectomy?
No. I think we'll go
Fusion.
for fusion.
Okay, everybody will do fusion.
My boss would do a discectomy. Dr. Gujraj would do a
Okay.
discectomy again.
Yes.
So this is now May 2025, and somebody did just a open discectomy this time. And this is post discectomy. Patient doesn't have any relief now.
So this is third surgery now, sir, right?
Yeah, third surgery, open discectomy, and patient doesn't have any relief. He underwent a open discectomy in April. So that's just jumbled up. So that's I missed one slide somewhere. Okay, so that's before, and April somebody did April 2025 somebody did a open discectomy, and he doesn't have any relief, and this is in May now.
This is a pain is mainly in the back or leg or both?
Back pain, left more than right leg pain.
No, I think the disc void is completely there, and though it looks like a good height, but there is, when on loading, there is a reduction, a lot of facetal friction, a lot of nerve root impingement, and it's all mechanical compression which is contributing to leg and back pain. It needs a revision. It needs to retain the disc height, to do a fusion surgery and restore the biomechanics of the lumbosacral junction.
So you straight away advise, April he has already undergone one surgery, you will straight away advise again a fusion surgery now?
No, if he's in symptomatically in a lot of pain, if the pain is 7 to 8 on 10, if it's not settling with the painkillers, you should not keep giving it for a long time, because there are a lot of problems of painkillers also,
Anybody has any other observation here? Sorry.
Guru, can I ask a question?
Yeah.
So there's a contrast MRI you are showing, right?
Yeah, there is a contrast MRI.
Yeah. It does not show any disc fragment, nothing. It's only granulation tissue and scar tissue around.
Okay.
And his pain is predominantly back pain.
Back pain and leg pain. Left leg pain, severe leg pain, which is not actually reducing with I'll just show you what happened to this. Just I'll again share back 1 minute. So he is not responding to the treatment. It's not going ahead. Okay, it's here. So that's the X-rays. This is the neurology. So this is now. Now are you alarmed? This is October now, from May.
Oh, there's infection.
Yes. So if you see closely the contrast MRI, if you see the end plates are enhancing there. So if you see here,
inside the disc, that haparin signal and around the discectomy tract now retrospectively looks very suspicious. And on the axials on the right side, you can see the end plate uptake,
Yeah. So, so this was in May. They gave some antibiotics for a week, and then he stopped it. So now this is October. What next? I have axials also. So if you see here, there is something here which is on the left side, and you can see that there is definitely end plate changes and end plate edema.
Any change in the clinical picture from May to October, Guru?
No, it's remained the same. Pain severity almost the same, not changed much.
CRP.
Okay. That's the X-ray.
No end plate erosions. Okay.
No end plate erosion, but he has a significant list now.
Yeah.
To the opposite side.
Yeah. CRP.
That's his TLC, neutrophils, ESR, and CRP.
Okay. So yeah, suspected infection. Neutrophil 78.
Yep.
Diabetic?
No, not diabetic. Non-diabetic.
Okay, because less. So much of no end plate change with pyogenic discitis is quite rare. I will think of a fungal infection in this fellow. And it's from May to October, 3 months. It's been progressive, and there's no end plate changes, and he had only antibiotic for a week.
Yes.
Right. So I will suspect fungal infection in this man. I would, with the X-ray CT scan.
We didn't do CT scan, so that's the only X-rays. We didn't do CT scan because end plate looked quite okay. So
yeah, this time no contrast MRI, is it?
This time because it was very obvious here that there is some infection going on. So I thought there's no need for contrast.
These are the three things. This can be infection. You can think, as I said, very, very indolent, slow infection, not a pyogenic. Yeah.
Any other thoughts?
Chemical discitis is another one. Wash
Chemical discitis with what?
Wash. Your saline wash itself can cause.
Okay.
Yeah.
Anybody else? Any thoughts? Okay, Appaji, what will you do?
I mean, patient with severe pain, back pain, leg pain, whatever, I will debride first, stabilize, fuse. I won't shy away from using a titanium cage. I will not use a peak. And pack lots of. I will harvest cancellous bone for this man, and I will pack with lots of graft.
So mono 1-level fusion.
Yeah, the X-ray looked fine, right? So why should you go to the other level?
Okay, so that is what we did. We did a standard, basically, MIS T-leaf, not MIS mini open T-leaf, and used a titanium cage as Dr. Appaji said. So we didn't use a peak cage.
How is the patient now?
A patient is walking around. Pain is completely gone.
ESR, CRP?
So we have to just operated in this month only. We will follow it up. We have started him on.
How's the culture report?
Culture didn't grow anything in 48 hours. And we have sent for a fungal culture and AFB culture. TB PCR was negative. So we have kept him on antibiotics for some time, and we wanted to add a oral antifungal, but then physician said let's wait till the culture report comes. So we are just waiting for the cultures.
So Guru sir, just a question to you. At what step you would have gone for a fusion? I mean, after how many surgeries? As an experienced boss that you are, so your tolerance for going for fusion for recurrence is after how many surgeries?
Okay, so the thing is, if it would have been a third recurrence within very short time, then definitely fusion. But then after 2 years, 3 years, like the patient who is like a trekker, who takes people on trekking trips and all. So I would discuss with the patient I would tell him that if the third recurrence, there is a high chance that there can be a fourth recurrence. So if he is ready to accept that risk, and then we can do just a discectomy. And it also depends on already how much bone the initial two surgeons have removed. If I feel that pars has become too thin, facets have been taken out a lot. If I take out the facet, I am going to create an instability, then I will fuse. But if it would have been a good surgery, then I would give an option of a discectomy if patient opts for it. But if it is left to me, I would do a fusion. Yeah.
Okay, sir.
I think well done, Guru. I think it was a lot of learning, and these cases make you more wiser. And it's always next time if it comes to you, what you will do next is the question. And if you feel that you should have waited or you should have done fusion earlier, I think that gives you that impetus to do it at the next time. And it's always learning for all of us. It was a wonderful case, Dr. Gururaj. I would like to request Himanshu to quickly summarize the review of literature before Dr. Nene takes over for the concluding remarks on the complete webinar.
Okay, so we are running short of time, so I'll just summarize in a short way. So review of literature, post-operative leg pain, you can see all the surgeons who are spine surgeons, they are still very actively involved for 1.5 hours of a webinar because it's a topic which is very close to their heart. Everybody's heart, because post-operative leg pain is something that gives you sleepless nights always. So you have to be careful. You have to consider some factors always. So which are the most common causes which are mentioned in the literature? So I'll just run through that very quickly so that we can summarize it. So post-operative leg pain review, literature of the review, overview, there is no exact amount of, there is no exact percentage which is available. In literature, it varies from 5% to 40%. It can be between anything. So there is no exact amount which can be quantified for post-operative leg pain. But post-operative leg pain is something that contributes very majorly to a concept called as failed back surgery. So failed back surgery, the maximum chunk out of that is post-operative leg pain. So what are the factors that you have to consider when you have a leg pain? We have discussed everything through these wonderful cases. I don't have to get onto that in very details. So first can be a recurrent or residual disc herniation. As Shailesh sir always says, if it is my disc, it is recurrence. If it is your disc, it's a residual disc. You have not decompressed well. That is what everybody says. So you have to look for a recurrent or residual disc herniation back in the back, because this is one of the most common causes of postoperative leg pain. Second is epidural fibrosis or epidural scarring. You have to go through literature. There is ample amount of literature. You cannot shy away from doing a contrast MRI to go through this. Third is inadequate decompression or missed foraminal pathology. Abhay sir always says in conferences that minimally invasive surgery does not mean a minimal job. Through a minimal approach, you have to do a max job. So just because you have taken a small incision, you cannot just do inadequate decompression and come out. The patient is always going to have residual leg pain. Fourth important thing is hardware related problems. So now the amount of fusions that everybody is doing is very high, because dynamic x-rays and all the indications for fusions have become very much well expressed in the literature. So the amount of hardware related complications are also getting bigger and bigger. So you always have to check for your hardware. No hardware comes without a complication. So decompression comes with its own long-term problems maybe, but hardwares are always going to give us some short-term complications. You always have to choose your patient wisely. You have to check your hardware before closing adequately all the routes and everything. And you cannot be inadvertently putting hardware everywhere. So that is going to give you some amount of leg pain if it is not placed very properly. So hardware related problems, inadequate decompression and I'm going back. Post-operative hematoma, this is very common. Post-operative hematoma, you always have to keep a drain. With minimally invasive procedures, the isolated hematomas at isolated root are becoming more and more common. You will find a lot of literature related to endoscopic hematomas and isolated root-related pains. So even though you are operating through an endoscope, you always should put a drain to avoid a post-operative hematoma and post-operative symptomatic leg pain. Next important thing is infection or inflammatory causes. Infection is not going anywhere. it is always going to be there as one of the most important complications. So infection and inflammatory causes are going to give you leg pain. Don't shy away from taking blood cultures, blood investigations, and doing repeat imaging if you're suspecting an infection. And last most important cause, which is most obviously ignored while you're doing something, because you have operated, you always feel that the cause is during the cause has been established during the surgery. There is something wrong in the surgery, but there are always non-spinal causes which can give you leg pain. There have been multiple case reports and abundant literature about a sacroiliitis which was missed because you fused a 5S1 and you thought it was a disc that was giving a gluteal pain. That is one of the most common post-operative leg pain, which is missed sacroiliitis. That is one of the reasons, but there can be multiple causes which can give you a post-operative leg pain, which are not coming through your spine. So stop thinking as a spine surgeon for a while. Start thinking as a clinician for a moment and think about the other causes that can be there, which are going to give you leg pain. So when you have post-operative leg pain, the main 5 things are: you have to keep patience, you have to investigate it thoroughly, you have to counsel the patient very well. Dr. Kundani, Dr. Gururaj, Dr. Nene sir has established the importance of counseling when you are talking to the patient, when the patient has post-operative leg pain and you are very frustrated. You have to have low threshold for investigations. Don't shy away from getting an MRI done or a CT done and establish the cause for the leg pain. It is not going to go in vain. It is going to only help you. Infection is always a possibility. You always have to keep infection in mind. You cannot win over microbes. You are going to perish, and microbes are going to be on this planet even after the human race is done. So infection is also, think about that. And it is very difficult for a proud spine surgeon to accept that you may be wrong. But when the patient has leg pain, you always have to think retrospectively and you have to accept that you are wrong and counsel the patient accordingly and treat the cause which is giving a post-operative leg pain. Okay, thank you.
Thank
So
you,
that's
Manju,
quite
for that
nicely
nice
summed up, Shailesh. It's very nicely summed up. And I think thank you, Shailesh, for picking this topic because it brings out such an important, part of our sleepless nights. And I think everyone bought this, bought this home well. Some of the causes that we didn't mention, of course, there are multiple more, but you can have a dural tear with a hernia of a root, and that can cause unrelenting pain. And unless you re-explore, you're in trouble. Wrong level surgery, we didn't talk about. And I think this is all feeders for our next few Spine Connect meetings because these are going to be very interesting topics to, discuss. Root handling in redo situations can give low back pain, can give post-operative leg pain. And we also discuss what the threshold of different surgeons is to actually re-explore versus to do investigations. But I think one thing's for sure that you should have to take the patient into confidence. It's a very good idea often to get a second opinion. If you're lucky enough to get a shot at your own post-op leg pain, I think you should count your blessings because it's better you do it than the patient go to somebody else. You have to save each other's asses and make sure that you speak well about your colleagues because today it's someone else, tomorrow it's going to be you. Keep calm, assess the situation well, but I think what's the bottom line is that use a third party approach. Deal with your own post-op leg pains as you would deal with others and vice versa, and that'll give you the right sympathy. So I think that's where we stand. And I'm sure the coming topics that's in a fortnight from now is going to be even more interesting. Shailesh has it up his sleeve, but he's not going to tell us just yet. So thanks, Shailesh. Maybe you can just conclude now.
Yeah, I think thank you all of you, the esteemed faculty and all the viewers are all across the globe for this wonderful interactive first webinar of Spine Connect and looking forward for the next one in the month of November. We will keep you posted. Thank you guys. Thank you. Good night. Good day for some. Thank you.
Thank you all.